Okay. And I'm just going to go ahead with the go live here. Okay. It looks like we're live. Hello, everyone in Facebook land and on all of our other platforms. So glad to be here today, this evening with Elysia Davis from Natera Women's Health. And we're going to be talking about breast cancer and genetics, and really excited to have your questions and to just learn more. So without further ado, I will introduce you all to Elysia. Thank you so much for joining us today, Elysia. Can you tell everybody what your role is at Natera?
Absolutely. Thank you for this opportunity. I am completely thrilled to be here. So I am a genetic counselor by training and have served as a genetic counselor for about 10 years. Most of that time has been spent counseling patients who are at risk of hereditary disorders in their family. And at Natera, I serve as almost like a medical consultant. So what I do is I sort of act as a bridge between the laboratory that performs genetic testing and the providers who offer the genetic testing to their patients. So this stuff is complicated. So I'm sort of like a technical resource for the doctors, midwives, nurse practitioners, anybody offering hereditary cancer testing or reproductive genetic testing.
That's amazing. Wow. That must be a really interesting role. I can imagine how just different every day must be, and the different kinds of connections and networking. Yeah, that's wonderful.
It's very interesting, endlessly challenging, and very rewarding. It's cool.
Yeah. I think a lot of what I notice is that people that work in this breast cancer space or cancer space, women's health in general, it is very rewarding work, empowering others, and just really wonderful. Well, so I know that you've got a great presentation to share with us, so I definitely want to start with that, but I want to let everybody out there know, if you are watching this live, that you can ask questions in the comments, and I'll be monitoring for that, and I will be sure to ask Elysia that as we go throughout. If you're watching the recording of this, which we'll be sharing afterwards, you can certainly go onto any of our socials and send messages through there, or you can send an email to info@goingbeyondthepink.org. We're happy to reach back out to Elysia and our friends and sponsors over at Natera, just to get answers to the questions that you have. They've been so generous in supporting Going Beyond the Pink at our dance party, and then in offering to do this educational session. So I'm so excited to continue to learn more about it. You can take it away, Elysia. Thank you.
Thank you. So this is very thoughtfully timed because Thanksgiving is National Family Health History Day. So Kira and I decided that this would be a nice time to talk about the relationship between family history and cancer and genetic testing. So what I will do is talk a little bit about cancer in general, sort of the biology of cancer, because there's a lot of mystery surrounding the biology of cancer and how genetics plays a part. So I'll go over that a little bit. We'll talk about how genetic testing may be beneficial to an individual and their entire family. And we'll talk about the resources that are available to you on Thanksgiving. As you meet up with your families, you're encouraged to talk about your family medical history. And I'll start with a kind of a silly little thing. I was telling a friend of mine about this talk tonight, and she said, this would be a great opportunity for families who are getting into arguments about politics. This is a great way to change this subject.
Isn't it?
So there's just a free piece of advice there. So
I love it. That's brilliant. See, that's your first takeaway, everybody, is, great topic changer. And that's really valuable.
Politics. Let's talk about something lighter, like cancer.
Like cancer and genetics.
That's right. So you all know this number. We know 1 in 8 women roughly is diagnosed with breast cancer in her lifetime, but the vast majority of those women don't have what we consider to be a hereditary or what's often just called a genetic type of cancer. So we'll talk about that breakdown a little bit, but hereditary cancer testing can be very powerful because it tests for genes that cause certain types of cancers that run in a family, whereas most cancer is not necessarily hereditary, doesn't really run in a family. And it allows the patient and their entire care team to plan for cancer risk reduction in a very mindful and forward-thinking way, and even prevention before cancer occurs based on that patient's very specific results. So this is really blossoming into what we call precision medicine, where instead of having a one-size-fits-all approach to cancer treatment, this is very much individualized based on a person's genetics. So only about 5 or 10% of cancer in general is actually hereditary, meaning that it came from a gene that you were born with that runs in your family. So it's a pretty small percent if you think about it in a percentage. If you think about it as a fraction, we're talking about 1 in 10 to 1 in 20 people that have cancer have a hereditary. So that those numbers may sound differently depending on how you approach percentages and fractions. But you know, as someone that sees, let's say I see 10 patients a day, one of those is going to have one of these genes, right? The next biggest chunk is what we call familial cancer, which means there is a lot of cancer in your family, and we can't necessarily find a gene that explains why. So we think that those families maybe have a combination of multiple, maybe low impact genes, plus some shared environmental causes. So maybe they live in an area that has a high level of pollution or something like that, that, you know, the family shares that risk as well. But the vast majority of cancer, about 70%, is what we call sporadic, which is just a fancy word for random. So this, I think that as difficult as it is to learn that you have a genetic type of cancer, it's also really hard for patients to sometimes get negative or normal results on hereditary cancer testing, because it just means that your cancer was random. And that can be very hard psychologically to digest, because especially women, we want to have a scapegoat. We want to have something to point to that says this is what caused it.
Yeah, we just like to know.
We just like to know, you know, so even if it isn't necessarily actionable or useful, we still just want to know, where did this come from? But unfortunately, a lot of, you know, fortunately or unfortunately, a lot of people that do this testing will have normal results because their cancer was not the hereditary type. So what is the difference between a sporadic or random cancer and a hereditary cancer biologically? So, you know, when you go through genetic counseling programs, kind of the joke is all cancer is technically genetic, because all tumors grow from tissue that has lost its ability to protect you from tumors. And that ability comes from our genes. So we have lots of genes in our DNA that their entire function is to protect our body from the development of tumors. These are called tumor suppressor genes. There's some other types that protect our body from cancer. They're really, really important gene. And generally speaking, most of us are born with 2 copies of those genes that are completely functional. We got one of them from our mother and one of them from our father. And they work together with our bodies to catch mutations from our environment, like UV radiations, cigarette smoke, etc. And they sort of correct those mutations and they protect our body from tumors. But over time, we can acquire these mutations from our environment, and that those genes maybe miss a step. So over a long period of time, decades, we may see the acquisition of one mutation in one of our genes, but we still have that backup that's working. So we don't see tumor development at this point, but over more decades, we may see that that other gene is impacted by a mutation, and that's what leads to tumor development. This process, like I said, takes a very long time, which is why most cases of things like breast cancer affect older women, because these mutations happen very slowly, because our body is pretty good at protecting us from cancer. Now, go ahead.
I've heard before, and I don't recall the number, I'm wondering if you do, the number of mutations that happen in our bodies every day that our bodies are able to repair. Does
I
that
mean,
ring a
many,
bell with
many,
you?
many, many. Yeah, I don't
Yeah.
know a number. I couldn't even hazard a guess, but you think about, almost every single cell in our body has DNA, and we are constantly exposed to environmental things that may mutate our DNA. So UV radiation, so sunshine is one of those, right? Every time you're outside
Right.
without a thick coat of sunscreen, you are hit by radiation that can damage your DNA. But
Right.
our body's really good at dealing with that in
And
general.
it's interesting too, because think about it, we need to be outside and in the sunshine for that vitamin D production.
Right.
So the same things that are good for you in excess are not, but our bodies are designed to deal with that through having
Yes.
both pairs of the genes.
Exactly right. So our bodies have been designed to deal with this damage. I mean, there's no way to avoid all of the environmental causes of mutations. Some of it just comes from like our planet being in space. There's just space radiation, right?
Yeah.
Or, the factory down the street or car exhaust, all of these things. There's no way to just live a perfectly clean life, but that's okay because our bodies are good at this.
Yeah.
Now, hereditary cancer occurs when someone is actually born with this mutation already damaged in every cell in their body. So they kind of have that one strike against them. So the time that it takes for them to acquire that second mutation is shorter, which is why you tend to see hereditary cancer happening in younger people.
Yes.
Because you're sort of missing that second hit that you need to have. So you see younger cancer, you tend to see more aggressive cancer. We'll talk about all the red flags for hereditary cancer, but that's what's happening, is that you're born with this mutation. You still have that backup working. So that's why not everyone with a gene will develop cancer. But if you do, it tends to be earlier. So there's still a lot of chance involved here. Having one of these gene mutations does not necessarily mean you will develop cancer. It just means that opportunity happens often sooner. There are certain things that make us think more about hereditary cancer, things that make us more suspicious when we take a family history as genetic counselors or your oncologists or whomever is taking your family history. So cancer diagnosed in young people for the reasons that I just described. Multiple primary cancers, so multiple cancer sites, so maybe a breast and an ovarian, or maybe a pancreatic and a colorectal. And that's because, again, you have this gene in every body or in every cell in your body. So it's affecting multiple tissues. Bilateral disease in any parts of our body that are doubled. So bilateral breast disease, bilateral ovarian cancer, bilateral kidney cancer, that would be very unusual if it was a sporadic type of cancer. Rare cancer, so pancreatic, maybe like some sort of endocrine cancer that's unusual, something like that. Ovarian, pancreatic, those are the two big ones. Brain, that's not a benign tumor. So anything that's just sort of really outside of the norm, stomach, bladder, those would all be weird ones that would make us think more about hereditary. And then, of course, if there's lots of cancer in the family, right? So we don't know from the beginning if that's going to be a familial type or hereditary type, but these genes are passed along by our parents. They're passed to our siblings, our children. So you see a lot of cancer in hereditary families.
I think that's really great too, how you've helped us to understand that. Because I think, I know when I work with people and I talk to people, there's often a really big misunderstanding between the difference between familial and genetic, right? They don't seem to get it. Like how are they different? So this really helps to clarify that and see,
Yeah. And the scientific word that we use is monogenic, which means there's one gene that's causing the cancer in this family. Mono meaning one, genetic, one gene, versus just sort of a multifactorial is what we call familiar, which is sort of a little bit of a catch-all for maybe a bunch of genes,
all these things, right?
Maybe some environment and shared lived experience all came together to make this family have a lot of cancer. The percentage of cancer that is hereditary varies by organ system. So about 10% of breast tends to be hereditary, but only 5% of endometrial and even less cervical. Those tend to be more environmental cancers, but much more ovarian tends to be hereditary. So again, the more rare, the more likely it is to be hereditary. And I've put my little male on here. I have a whole slide on our boys. We can't forget that these gentlemen don't have breasts and ovaries, but they sure can get these genes.
Yeah.
So we actually see a higher risk of male breast cancer, even colorectal and prostate cancer in these guys.
And I think it's interesting too. I know, as health literate as I am, even prior to my own cancer diagnosis, I didn't realize that the genetic mutations could be passed down through the man in the family, right? And I know that a lot of other people also think that too, right? They think that if they're going to get breast cancer and it's a genetic thing, it's going to come through their mother. And mine actually came through my father's family. And so that's kind of how I got around that to that knowledge. But, we are seeing a lot more male breast cancer, even though that it is so rare. And I'm really glad that you bring that into it's really important to talk about. So male breast cancer, you're saying between 13 and 40%. Why is that such a big range there?
Great question. It depends on the gene. So some genes and even some mutations within one gene can have different effect sizes. So some genes have a pretty low increased risk for certain cancers. Some genes have a much higher. Some genes, it really depends on the type of mutation. So there can be a lot of variability. That number may also be a broad range because breast cancer in men is pretty underdiagnosed. So you see a lot of gentlemen that maybe had male breast cancer, but it was detected late enough that the mets are then everywhere and the primary is unknown. So there's a little bit of an unknown there. But you're absolutely right. And I think that health literacy doesn't have as much to do with not understanding the male dynamic with hereditary breast cancer. I have doctors that say, well, she just has sons, so she doesn't need to worry about her kids. Right. So this is a very
well, that makes me feel better. Thanks, Elysia.
It's a very normal misunderstanding. Just because they don't have breasts does not mean they can't get the gene and then pass it on to their daughters. So this is a conversation,
sons, right?
Yes, exactly. So why is her genetic testing helpful? So first of all, screening. So we want to catch cancer early. Obviously, this is not news to anyone here. But the intention with genetic testing is not only to catch cancer early, but also maybe do risk reduction or prophylactic surgeries, something that can decrease the cancer risk before it even has an opportunity to develop. And I'll talk about those strategies in a bit. But hereditary cancer testing can also give you access to increased screening that your insurance maybe would not have covered unless you did have the gene. So for example, I'll show this in a little bit, but there's screening recommendations for people that have one of the more common breast cancer genes, BRCA1 or BRCA2. There's very clear guidelines about how often those women need to be having mammograms, even breast MRIs. But breast MRI is not something that is typically covered by insurance unless you have a compelling reason to have that screen. This testing, if positive, will tell your insurance company she needs this, and then your insurance company will cover all of this surveillance. And then of course, family. So we want to, every single first degree relative of a positive test person has a 50% risk of also having that gene, males and females. So this is really not just testing one patient. This is an entire family system dynamic that we're working with. 1 in 4 women meet the criteria to have this testing. So the NCCN guidelines, that's the parent organization that gives us guidelines about how cancer should be treated, and they speak to how hereditary cancer testing should be implemented. This is what insurance companies follow, and about 1 in 4 people have a family history that is compelling enough that they qualify for this testing through their insurance company.
Yeah. And going back to, Thanksgiving coming up and, taking that opportunity to get to know your family medical history, right? Your physician will use your knowledge of your family medical history, what you share with them about your family medical history, to do this assessment. Isn't that right?
Correct. Yes. So what laboratories like Natera do is they'll provide doctors with a questionnaire. Your doctor may also have questionnaires that they made themselves. There's also questionnaires available from any number of nonprofits, but the questionnaires are targeted to follow the NCCN guidelines and say how many people with breast and at what ages, how many people with ovarian cancer and at what ages, et cetera, et cetera. And those guidelines match what the insurance company is looking for in terms of coverage for this testing. So we provide that, and that's what the doctors use. They usually do it at like an annual visit, maybe a GYN visit, any kind of annual physical, well woman visit, that kind of thing.
Yeah. Yeah. So knowing that, you have to actually really know your family medical history and not just, oh, I think Uncle so-and-so had breast cancer, or,
Yes,
yeah,
exactly.
it's really important to know those details and write it down, because you'll forget, especially in a high stressful situation.
Yes, I will. Everyone forgets once they're on the uncomfortable table in a paper gown, what they talked about. So I completely agree. Write it down. And I'm going to show you some resources at the end with example questions that you can ask your family and how you can log the answers and make it kind of fun for the family.
Oh, excellent. Thank you.
Of course. I cannot tell you how many times I talk with a doctor and they say, well, she said that her aunt had some kind of female cancer, but I don't know if it was cervical or ovarian, so it really is important to know where was it in your body. In your abdomen is not helpful, right?
Right.
So we'll talk very specifically about BRCA1 and 2 for a couple of minutes. These are the most common genes that cause hereditary breast and ovarian cancer, which from here on out, I think is abbreviated as HBOC. So when you see that, that's what that means.
Got it.
And the hallmark cancers for these two genes are breast, ovarian, pancreatic, prostate cancers, and then melanoma actually as well. And it's pretty common. So about 1 in 300 people in general have this gene, but it is much more common in individuals of Ashkenazi Jewish ancestry. So if you know of any Eastern European Jewish ancestry, this is much more common for various reasons. But 1 in 300, again, sounds rare, but that's pretty prevalent. If you think of, I don't know, how many people came to your wedding, right? Like maybe 1 or 2 of them.
How many people you graduated school with or anything like that. Yeah.
So
and can you go back one slide real quick? I just had a question. So I think people are pretty well aware that BRCA1 and BRCA2 can increase risk for breast and ovarian cancer, but some might be a little bit surprised to see that it also increased the risks for pancreatic, prostate, and melanoma. Can you talk a little bit more about how much it increases the risk for that?
Yes, I will.
I also want to add, and I'm sorry I don't have it, written down the source, but I recall reading that for men that have a BRCA1 or BRCA2 gene mutation, that the type of the type of prostate cancer that they get is often a more aggressive, harder to treat one. So I wanted to make sure to check in on that with you.
Yes, I will address both of those things.
Oh, great.
But yes, generally speaking, cancers, when you have one of these hereditary syndromes, tend to be much more aggressive across the board. So I'll talk a little bit about that. So red flags for these conditions, like I said, early onset. So we're talking about premenopausal breast. Postmenopausal breast tends to be more sporadic in nature. So earlier is more suspicious, and then 2 primary breast cancers. So that means if you had breast and then you had a recurrence 10 years later, or if there's 2 sisters that had breast cancer. So anytime you see 2 breasts in the same kind of cluster, 2 or more of these types of cancers on the same side. So maybe there's a breast and a pancreatic, or a breast and prostate. Really any of the rare ones. So ovarian, pancreatic, or male breast, I don't care if they're 98, that's suspicious. And aggressive cancer. So what we call triple negative breast cancer. So this is breast cancer that has all of the helpful receptors missing, helpful receptors for treatment. So those triple negative breast cancer is more likely to be due to one of these inherited conditions. And then again, if you have Jewish ancestry and then any one cancer. So if you're Jewish and there's an aunt with breast, that's an automatic qualifier to this testing. You mentioned the severity of the conditions. Prostate cancer is most often just confined to the prostate. It's not terribly common for it to metastasize quickly enough that someone is missing it if they're getting their annual exams. But if it's metastatic, we get more concerned, hey, this is an aggressive prostate, and maybe this is more likely to be due to BRCA1 or BRCA2.
Interesting. Okay.
This is an upsetting statistic, and this is why I'm here tonight. About 80% of women at risk for these conditions never discuss genetic testing with a single healthcare provider, their GYN, their family medicine doctor, their internal medicine provider, whoever that is. I'll also add that this statistic is even worse when you look specifically at underserved population. So if you look at people that are Black or brown, if you look at people that have less medical literacy or people with lower socioeconomic status, these numbers are even worse. Some of this is due to access issues. Some of this is also due to provider biases. I think that there's a lot, I mean, I don't think, I know because this is my job. There's a lot of provider education that still needs to be done about hereditary cancer conditions. There's a lot of misunderstandings. For example, I've talked about a Jewish, increased risk in the Jewish population. I've met doctors that think that this only affects Jewish patients. But the reality is, if you take, there's one study that took young breast cancer survivors, about 1,600 young breast cancer survivors, and if you looked at the rates of mutations in those women, they weren't any different, Hispanic, Caucasian, African-American, or Jewish. So if you actually look at cancer survivors, they're just as likely to have these changes.
Wow. This really is an upsetting statistic, 80%.
It is.
And I can't help but to kind of think back to my own story, because no one had ever mentioned, and I was very regular about going for annual exams, physical exams, all of that kind of stuff. And no one had ever mentioned getting any genetic testing. And I was also pretty good about sharing family medical history, but I have Ashkenazi Jewish family, and an aunt who had breast cancer, which by the way, wasn't genetic, but had like second cousins. And so that had breast and ovarian cancer at young ages and had died at young ages from it. And yet still no one had ever mentioned genetic testing. So it's an awful statistic, but even just from my own personal experience, I imagine that, yeah, it really does apply across.
It's upsetting, and I'm sorry that was not discussed with you. It is getting better through things like this, educating the public, educating providers. That statistic is getting better. We're closing the gap, but there's still a lot of work to do. So of course, there are fewer groups louder than breast cancer survivors.
I would agree.
So, take this ammunition and go out in your community and say, hey, everyone with a family history needs to get this done. That's why we talk about this today before Thanksgiving, so that you can really empower your family members. Hey, I had breast cancer at 32. Let's talk about what we need to do as a family.
Right. That's a big takeaway from this too. And thank you for saying it that way, because, if you're watching this, and we've got a bunch of people watching us live right now, and there'll be lots that come on later. If you're watching this and you want to know, what do you do with all of this? Share it, share the video, but share the information, right? Go out and tell people that, they need to be asking if they qualify for genetic testing, why it would be valuable to them. I think about the conversation that I'm going to have with my now 13-year-old daughter when she's older, to talk with her about, why she should have testing done and how that will empower her to be an active participant in her health and her health care, and be able to make decisions about, maybe what's the word I'm looking for?
Prophylactic, yes.
Prophylactic, thank you. Getting prophylactic surgery so that she doesn't have to go through cancer. And of course, those decisions are really personal and intimate decisions. And I'm not necessarily saying, advocate for someone to do that, but when you are empowered with the information and you understand what that means to your risk, you can make very different decisions about your screening rates and patterns, or do you take medication? Do you get surgery? Because there's a lot of choices that people get to make. And if you don't know, then you can't make those choices. This is so wonderful. Thank you so much, Elysia.
Of course, absolutely. And I completely agree with you. I think, again, the culture's changing, but in many families, people are still very hush hush about medical stuff, right? I mean, I think about some of my family members. I'll say, well, what did grandpa die from? Oh, he was old. Okay.
Okay.
Right.
But yeah, there was something that caused
there
it
was
to
something.
happen, right?
But you're right. If individuals don't have the opportunity to gather this information and be proactive in the way that speaks to them as an individual, then they can't make that choice. You're just removing that choice from them and making the decision for them. So I think about years and years and years ago, this wonderful older gentleman who came in because his sister had BRCA1, and he wanted the testing for his daughter. And his daughter was in her 20s. She had just gotten married. And frankly, she was very angry that her father had withheld this knowledge until she was in her mid-20s and married, because she said, we've been talking about waiting to have children and, planning our careers and everything in a way that we didn't imagine being interrupted by cancer.
Right.
So maybe my new husband and I would have planned our lives quite a bit differently if I had had this testing, when I was 20 or 21, ready emotionally and financially and mentally, but also able to then sort of course correct if I needed to, whatever the case may be. So it was.
And you think about the impacts of a cancer diagnosis in the young adult community, right? I mean, if it's genetic, they're more likely to get it at a younger age. And people that are in those age ranges where they're getting it than the young adults, it's impacting their finances for the rest of their life, their fertility choices, right? There are so many things that impacts. So it's knowledge you want to have earlier, right? Earlier the better.
I think so. But it is odd, like you said, a very personal choice.
It is.
So these are the risks. So there's never a zero risk for any kind of cancer. But as you can see, the risks with the gene, which is in the green bar, are quite a bit higher than the risks without one of these mutations that you're born with. So the breast cancer risk with BRCA1 or 2 is about 60 to 80%, depending on the mutation. Ovarian cancer is up to 54%, which is crazy high. Ovarian cancer in particular is very hard to screen for. So that one is really the emergency when it comes to BRCA1 and 2. Pancreatic cancer up to 10% when this is very rare in the general population. I want to talk about our men as well. So male breast cancer, like you said, there's a big range. This has different numbers. This is from NCCN. It says up to 8.9%. Prostate cancer risk goes up, and again, more likely to be metastatic. And pancreatic cancer again is high for these gentlemen. And this is just another point. It's not just BRCA1 and 2. So there are many genes that we know, this is just a few of them, that can cause an increased risk of breast cancer. So if you choose hereditary cancer testing, I encourage you to do what we call a panel of genes. So instead of just BRCA1 and 2, nowadays what we're doing is larger panels of really any gene that we know has some association with cancer. So at Natera, our more commonly ordered panel is about 40 genes. We have one that's 80 genes. We can go up to 200 genes. That's usually something that oncologists deal with. But for some, like a family medicine, internal medicine, or GYN provider, they're typically ordering like a 40 gene panel. So that's a pretty good size. It's going to cover all of your highest risk genes that have clinically actionable guidelines behind them.
I've got another question here, and
Sure.
it's coming from personal experience, but I also know plenty of other people who have gone through this same path that I have. So I did genetic testing after I was diagnosed with breast cancer. And I was able to reach out to a member of my family who had already gotten the testing done and found that they had the mutation, and they were able to provide me with a copy of their results,
Perfect.
right? So I was able to send that in, and it helped the lab move things through more quickly. But they were able to identify the specific germline where my mutation was and say, yes, indeed. Is there benefit to me? And, that was 9 years ago, right? Is there benefit to me and to others like me who went through that path in getting additional genetic testing done? Is it likely that I might have mutations in other genes and have other genetic mutations been identified in, say, the last 10 years that we didn't know about before that?
The thing that I love about working in genetics is that it is evolving every single day. There's constantly new data. It's really hard to keep up, but that's why genetic counselors exist. We have a very niche job, but our job is to keep up with all this. So yes, if you had genetic testing 5, 10, or 15 years ago, it is worth a phone call to whoever did that testing for you and say, hey, is there anything new that I should be doing? Sometimes they can take the test that you've already completed and just do what's called a reinterpretation with current data. So they don't even need a new blood sample.
Right.
Sometimes they'll just take a new blood or saliva sample and rerun it with the current methodology, the current technology that the lab is using. The technology changes, the research changes, the data changes. We're learning about new genes and new mutations every single day. And it's the laboratory's job to keep up with that and incorporate all of these new changes into their tests.
And this answer is probably a given, but I want to voice it because others out there might be wondering and asking themselves the same thing too. If you have, say, the PALB2 genetic mutation and the BRCA2 genetic mutation, is your risk compounded then? Is it, or is it just the highest level of risk? Like, you know what I'm saying?
Yeah. So we don't know a ton about that because those situations, thankfully, are pretty uncommon. Now, in the situation that you described where there's a known gene mutation in the family, you did the exact right thing by providing that information to the laboratory so that they can be more specific about what they're looking for. Today, what laboratories are doing is saying, yes, thank you, we will test you for that. And we're going to go ahead and test you for these 40 other things anyway. Because it is common enough that there are 2 genes, or maybe there's one gene from your mom's side, but a totally different one from your dad's side, that we just say, you know what, we're just going to do the whole thing anyway, just to be comprehensive. But we're going to take an extra careful look at that one mutation. So what we called single site testing was when we just tested for the mutation known in a family. That was the standard protocol 10 years ago. Nowadays, we're more often, if the patient is interested, looking more broadly just to see if there's anything else going on. Now, some laboratories will offer something called a family testing program, where they will offer either free or reduced price testing to family members of someone who is positive. So let's say if you are a woman with children and you want your kiddos to be tested, some laboratories will do that testing for free. Natera is one of them, just to plug my laboratory.
Yeah, absolutely.
And when that happens, we're doing the whole panel. We're not just doing the one mutation that was identified in the first person.
And how old do children have to be in order to get tested these days?
Generally, age of consent, so generally 18. However, Some of these genes, unfortunately, can cause cancer risks in children. That's rare. BRCA1 and 2 are not one of them. We don't worry about BRCA until adulthood. But some, there's one particular gene that causes colorectal cancer, and children that have mutations in that gene need to start colonoscopies at age 10. So for that particular condition, we test minors, but generally, unless it's one of those types, we do recommend, it's not a recommendation, we won't perform the test on a minor.
Okay.
The reason for that is that there's a big belief in the genetics community of informed consent. And like you sort of described with your daughter, we want our children to be able to make a decision that's consistent with their beliefs and values. And for some of us, that's not doing testing or delaying the testing until some life milestone is achieved, right? So a lot of women will say, I'll get the testing when I'm done having my babies, right? Like I'll have my kids, get through breastfeeding, and then when I'm done with my ovaries, I'll do this
Then
testing.
we'll do it. Yeah.
Yep. Because they can't get through the childbearing years with that knowledge. Others say, I'm getting this testing on my 18th birthday because that is just the type of person I am. So that's going to be very individual. But there's usually a hard stop at the lab with testing minors.
That's interesting.
Yeah. So flipping this a little bit, sometimes one gene can cause many different types of cancer. So we've already kind of said this with BRCA1 and 2. This is a different example. MLH1 is a gene that causes something called Lynch syndrome. It causes a lot of cancer. So we think of Lynch syndrome as a colorectal cancer gene, but this also causes uterine, ovarian, renal cancer, bladder cancer, gastric cancer, prostate, and pancreatic cancer. So similarly with the BRCA1 and 2, if we have a gene, we want to educate ourselves about all of the different surveillance things that need to be completed, annually or semi-annually. And usually what laboratories will do and what your provider will do is give you that guideline, because these are published by the NCCN, and say, you need to do this every year, you need to do this every 6 months. So that's very clearly spelled out for patients and providers so that we can follow that plan. So this is what the surveillance looks like. This is sort of the table that we use at Natera on our reports, and these are meant to be patient facing so that it's just like as simple as possible for patients and providers to understand. So for breast, we're going to be doing breast exams anyway, because everybody needs to be doing that, but also we want clinical breast exams every 6 months, which is not the typical. Usually it's every year. We want breast MRI and mammogram every year, starting young, 25 and 30.
Both of them every year. That's really, I haven't heard that yet. That's interesting.
Yep. And what patients typically do is they'll stagger them. So they'll get their mammogram in January, and then they'll get their MRI in June. Ovarian, the surveillance for ovarian cancer is not great, but there's a blood test called CA-125 and then a transvaginal ultrasound that you can start having as early as 30. Pancreatic cancer, these folks are getting MRIs and endoscopies. So really pretty significant guidelines for surgical interventions, where the providers are going to start talking to you about risk-reducing mastectomy and what's called risk-reducing salpingo-oophorectomy, which is just getting your ovaries out pretty young. So generally they say as soon as your babies are done being born, or if you do not choose to have children, go ahead and get your ovaries out, because the surveillance is not great and ovarian cancer is deadly. We're trying to make better surveillance for ovarian. The surveillance for breast is great. So a lot of women will elect not to have their breasts removed and just do their MRIs and mammograms.
Yeah.
And then there's also medications that people can use if they do not yet have cancer, or do not have cancer, not yet, but do not have cancer. Birth control pills. So regular old-fashioned birth control pills that have estrogen in them can reduce that ovarian cancer risk by about 50%. And that's for anybody, by the way, if you have BRCA or not. But that is something that if you get the test when you're 18, the doctor's going to say, you know what, let's just go ahead and put you on birth control pills and reduce that risk as much as humanly possible.
Yeah.
And tamoxifen is a common oral medication given to people living with breast cancer. Some doctors may prescribe that before the onset of breast cancer to reduce the risk of a primary breast cancer pretty substantially by 62%.
Yeah. And isn't that because tamoxifen blocks the absorption of estrogen for in cells, and that a lot of this BRCA particularly is estrogen sensitive cancers?
Exactly
Is
right.
that? Yeah.
Exactly right. Yep.
Yeah.
So the reason that you tend to see cancers in certain areas of the body, depending on the gene, is because those genes are more active in certain places in our lifetime. So BRCA1 and 2 are involved with estrogen, and so that's why you tend to see breast, ovarian, and things like that. So yes, exactly. Tamoxifen interacts with the estrogen receptors, and so it can decrease that risk.
Okay.
And we can't forget our boys. So this is, unaffected men are 10 times less likely to receive testing than unaffected women that have risk. We've already talked about they have these risks. This is a little what we call a pedigree or a family tree of a group of siblings. So 2 ladies, which are the circles, and a male in that 3rd generation down there who had a dad with pancreatic cancer. And this was one of those families, like you described, that they really did not believe that the brother needed to be tested.
Yeah.
And we have guidelines. So in our reports, regardless of the sex of the patient getting the testing, we will print the guidelines for males and females, because again, we want that patient to take this home and share it with their family members. So guys are getting mammograms, guys are getting prostate specific antigen, which is a blood testing for prostate cancer, and also rectal exams as early as 40. So that's earlier than typical. And pancreatic screening after 50. So I wanted to tell you a little story. This is not her real name, but this is someone that I was involved with, just to illustrate how powerful this testing can be. So this is someone just during her well woman visit with her primary care provider, reported that her dad had pancreatic cancer, and she herself did not have cancer. She is through with her children. She had 4 children, 3 of whom were biological, 1 of whom was adopted. Highly educated, very medically literate, very, aware that pancreatic cancer is concerning, but also not overly concerned about this history. But her provider ordered this testing, and she does have a BRCA2 mutation. So immediately she got on board, she started her screening. She's 37, so it's time to start that. They talked about, because she was finished with having her children, having her ovaries removed, they talked about future pancreatic screening. She ultimately elected to go ahead and have her ovaries out. And during that surgery, they identified that she had stage 1 ovarian cancer on those ovaries. And so they caught it early. She is now completely healthy. Her chemo knocked her down, but she's back up. And she's doing really well. So I'm very proud of her. That story gives me chills every time I tell it.
I literally, I'm actually experiencing that right now. Because without that interaction between, patient and physician, without even, what if she had gone in for that well woman visit and never mentioned the pancreatic cancer, right? There's just that information is so powerful, and it literally in this case probably saved her life.
I think so. I mean, unfortunately, most of the time ovarian cancer is diagnosed in stage 3 or 4. Very oftentimes when it has already metastasized, it is a very deadly cancer, especially, when we're 37. We're hustling, we're working, we have small
we're building careers and families and relationships, and we're not thinking about
nobody's thinking of this. The first symptom of ovarian cancer is typically bloating. Okay, I'm 36. I'm bloated all the time, right? I'm not thinking.
What depends on what meal you eat or when you're getting your cycle. I mean, there's so many. So it's easy to miss all of that.
It's easy to miss it.
And it's the same with breasts too, right? A lot of signs and symptoms could, they mimic the same kinds of things that women get during their cycle, right? Where,
Right. Exactly.
you might feel like a little lumpy or bumpy and, think, oh, nothing of it. That's why it's so important to do the self-exams and to know you're normal. And,
Right.
yeah.
So really exceptional point, Kara, that I have not mentioned is that because sporadic cancer tends to affect older women postmenopausal, you're not having your cycle symptoms anymore. So it's easier for you to pick up on unusual symptoms, vaginal bleeding, bloating, breast lumps, breast discharge, etc.
Yeah.
But if you're 37 and you're still menstruating and maybe you're breastfeeding and maybe you just had a baby and all of these things, it's really,
and that happens a lot. I mean, women diagnosed when they're when they've either pregnant or they just had a baby, and they were breastfeeding, and that's how it was found, or the hormonal surges and all of these things. We see a lot of it.
Yeah. So let's talk about, I wanted to end with this statistic. 62,000 hereditary cancers could be prevented or found earlier in the US through preventative methods. A lot of that is just routine screening, getting your pap smears, getting your medical breast exam. But that also includes genetic testing. So, the aim is to save lives and empower families.
That's an amazing number too.
Yeah, it's a lot of lives that we can affect. So Family Health History Day is on Thanksgiving. This was started in 2004 by the Surgeon General at the time. I cannot remember their name. But the intention is to have conversations not only about your cancer family history, but your risk for heart disease and high blood pressure and diabetes and all of these things. So if you just Google National Family History Day, the first link is going to be the CDC website, and it has tons of information here. So if you kind of scroll through, there are example questions that you can ask. So does anyone have any heart disease or diabetes? Has anyone had any cancer, stroke? What type of cancer? How old were you? What's your family's ancestry? Do we have any Jewish relatives? Do we, anything like that? Where did our ancestors come from? That's also just kind of fun to talk about on Thanksgiving.
It is, isn't it?
Unfortunately, does anyone know how old Grandpa was when he died and why and all of that? Then this little orange bar, this My Family Health portal is a really fun little tool. So I played with it a little bit. And this is a thing that you can use for free. And it took me about 10 minutes to go through and play with it. And what it helps you do is actually, this is what happens when you click on it. I'll go back to the turkey. You can create a family history on this website. You can save it to your computer. And I just built this for my family. This took me, I think,
I love this.
7 minutes. So here's me in the blue, my kiddos, my brothers and sisters, my parents. And then I hovered, and you can add everyone's medical history. So I hovered over my dad here so you can see he was recently, thank goodness, cleared. He had prostate cancer. So you can add all those details, and then you can print this. You can save it to your computer, and you can also, there's a way to email this to your relatives.
That's wonderful. And then with smartphones these days too, then you have it with you when you go for your visits, right?
Yep. Exactly. There's also this really handy chart that you can download after you put in all this information. I just kind of added a couple of little things. I didn't fill out everything, but you can see that you can put like a lot of medical information in here. And this is just a screenshot, but you can sort of scroll down. You can put as many relatives as you want. You can put names, you can put as much details as you like. So like you said, you can just have this on your phone and you can say, hey, doc, these are the things I want to talk about.
Sure.
So I thought that was pretty cool. They also have these little silly little graphic with suggested questions. So some of these seem so almost indirect, but it gets people thinking. So has any family member had a surgery or been hospitalized? Do we know why they had that surgery?
And that's important too, because sometimes we think about our family medical histories as a stagnant thing, right? Like this is something that happened in the past, and once I know about it, I don't need to update it. But we do all the time, because things are happening all the time to our loved ones and our family members, and we need to be, staying on top of what changes. And I love this, because we've been talking about it a lot in terms of cancer, right? But there are so many other health conditions that you would benefit from knowing your family medical history and keeping it up to date, because it helps you to, make choices about your healthcare.
Yes. So some of these are just going to be common human things, but that can run in families: heart disease, high cholesterol, diabetes, cancer, allergies. Some of the, we don't want to forget about our mental health. So depression, anxiety, bipolar disorder, schizophrenia, those are all highly what we call heritable, meaning there's a strong genetic component for those. And then also just classic genetic diseases: sickle cell anemia, cystic fibrosis, Parkinson's and Huntington's disease, anything that, do any of these things run in our family? You said that family history tends to be stagnant. If I had a nickel for every time a patient said, no, my family is all healthy, and well, they had this thing, but they're fine now, right? Like they had cancer, but it was treated and they're fine.
And they're
doesn't
fine.
mean that they didn't have cancer.
Right. We still need to know that, right?
That history
really
matters,
important.
right? I'm glad everyone is well today.
Yes.
But if they were born with a birth defect that was fixed, they were still born with a birth defect. Or if they had a stroke and they went through physical therapy and they're fine, they still had a stroke, right?
Yeah.
So asking those questions and really digging deep is hard. I have to acknowledge it's hard, especially for some families, but it's important. So the other tool that I found is through the NHGRI, the National Human Genome Research Institute, and this is called the Families Share Disease Work. You have these little worksheets. Share is an acronym. I forget what it stands for, but it's very similar. So you can, this is linked on the CDC's website. They have these very easy little worksheets that you can bring to your family. So this is mine. I picked the breast cancer worksheet, of course, and really it just says, any males with breast, any first degree relatives with breast, any second degree relatives with breast. It's as simple as that. If the answer is yes, you may have an increased risk of breast cancer. We recommend that you talk to your doctor. So you can bring that from your phone to your doctor. The CDC says we need to talk about this. Yeah. So very simple. So there's lots of these little things you can play with on the websites, and do it together as a family. Enter all this later. I tend to be a paper and pen kind of person. Just write it down, like you said, and bring it to your next visit.
Yeah, and you know what? Because I know that this happens out there. There are lots of families that are competitive. So for all of you competitive families, you can track this Thanksgiving and then challenge each other to see who can go to their physician first and share this information. Right? Get a little. And then win a prize for next year.
That's right.
Start a family trophy or something. Right?
And remember this testing, genetic testing, one of the things that has been true for very, very long is that it was expensive.
Yeah.
And we have thankfully reached a point where the technology has improved so much that the cost has come down, and the benefit of labs like mine competing with similar labs is that it keeps driving the price down, which is only a benefit for patients. So if you're thinking this isn't accessible, ask. It may be, my company, for example, we don't bill Medicaid, Medicare, or TRICARE patients. We have sliding scale for, based on income. There's all kinds of accessibility things. And then testing relatives is free. So like you said, if this year, maybe a cousin does test positive, let's get everybody done by next Thanksgiving.
Yeah, absolutely.
Yep.
Absolutely. This is fantastic.
Yeah. So that's all I've got for you. This is just kind of the rest of Natera Women's Health. Most of what I do has to do with pregnancy and fertility. But of course, this is a special love of mine.
This has really been wonderful. Thank you so much. We did have one question I would love to dive into if you've still got some time.
Of course.
Ellie asked, can PGT eradicate a specific gene in bloodlines?
Oh my gosh. Thank you for asking. That was a perfect transition.
Love it.
On this slide is Natera's PGT, which I'll define option, which is called Spectrum. So this is in my wheelhouse. So PGT is pre-implantation genetic testing. So this is a really fascinating, mildly controversial option that is offered to carriers of hereditary cancer genes. and carriers of other genetic disorders like sickle cell disease, where let's say you identify that you are a BRCA carrier, you're pre-Viver, which means you tested before you had cancer.
Yeah.
Let's say you're 20 and you meet the love of your life and you want to have a family, but you really would prefer not to pass on the BRCA gene.
Sure.
One may choose to go to a fertility clinic and go through in vitro fertilization or IVF. The embryologist and the specialist can then actually do a little biopsy of your embryo, test your embryo for BRCA, and then the doctors will only put in the embryos that don't have BRCA.
Oh,
Yeah, so this is
wow.
one option that Natera offers, as well as a number of other laboratories that do PGT. This is absolutely available for any one of our cancer genes. In fact, we actually have like a crossover program at Natera. If you do the hereditary cancer testing, ours is called Empower. We find that you have a gene, unfortunately, but you are of reproductive age and you want to do PGT. We actually have a deep discount. That testing can be very, very expensive, and it's about 1/10 as much if you have already done our cancer test. We give you a big discount for that.
Yeah.
So definitely ask your doctor about things like that. It is an option. It is, I'll just say, because I'm a genetic counselor and I am compelled to, nothing is 100%, nothing is guaranteed, but it does decrease the chance from 50% to less than 1%.
Wow. Wow. And I know that you mentioned that it's a little controversial, and, like a lot of things are when it comes to, picking and choosing things with genes, right? Sure.
Yeah.
But also I think at least the amazing thing is that you have choice, right? And when you know, and you have choice, you can make decisions that are right for you. That's really amazing.
Yeah, PGT is not for everyone, but it is for those for whom it is available and they can sort of wrap their head around it. And, IVF is it's hard on the body, it's hard on the wallet, but for people that are really motivated to avoid this family history, I mean, the cancer legacy is so traumatic. So I see PGT being used a lot in families that have just been traumatized generation after generation, and they're done.
Right.
And
that's
it's
really
worth it
amazing
to them to go through that process.
And I lied about having one question because we do have one more. What is the self-pay price if insurance does not cover genetic testing?
Great question. So it varies lab by lab. I can only speak to my company. The self-pay price is $349 maximum. So that is, we have to play with deductibles and copays and all of those things. Know your insurance. If, let's say, it's the beginning of the year, your deductible just started over and it's a $5,000 deductible, and you're not going to meet it this year, you could choose the cash pay price, $349. And then even with that price, like I said, we have sliding scale. So many patients in my area don't pay that much. Maybe they pay $149 or $99, depending on their income, or zero. So it's, labs are really, really making an effort to be equitable in how they offer genetic testing. This genetic testing has I'm so sorry. My rep Allie is correcting me. It's $249. Please excuse me. $249.
Thank you.
I am clearly not a salesperson.
That's even better.
That's even better. So $249 max out of pocket. And it can only go down depending on your income. And, one of the things that I take a lot of pride in is that I work for a company that is pretty well committed to accessibility and equity. So genetic testing has historically been for privileged people, and that has improved dramatically in my career. So I'm very pleased to see that tide turning.
Amazing. We're going to just do our part, right, to help increase the number of people that are getting the genetic testing and have that information and feel empowered. That's really amazing. And I think one thing that I've learned in working with patients is from that navigation perspective is always ask, right? Don't just
Yes,
assume that
yeah.
you can't afford it or you can't do it. You know, where there's a will, there's a way. So
Yes.
let's work on it. Let's figure that
Yep.
out. But I think, you know, at 249, that's still really, really reasonable. And to have other options, that really even makes it, you know, so much more accessible. Excellent.
Yeah. What other
Yeah.
questions?
I don't see any others coming up, but I will just again let everybody know, whether you're watching this live or if you're watching a replay of this, that you're always welcome to submit questions to us. We can definitely reach back out to Elysia and our
Absolutely.
other Natera family. But you can either submit questions on any of our social channels, Going Beyond the Pink or at GBT Pink, or you can send an email to info@goingbeyondthepink.org and we can help you get the answers that you need. This has been so enlightening and so
Good.
informative, and
Thank
I'm so excited for people just to be able to hear this and get clarity around what can feel really big and overwhelming.
Absolutely.
You know,
Yep.
this is incredible. Thank
Yeah.
you so much, Elysia, for joining us.
It's a pleasure. Thank you.
Yeah.
This is great.
It's been wonderful. All right. Well, thank you out there to everybody. And I'm going to go ahead and take us off the live. Bye, everybody.
Great.